Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Very excited to welcome my guest today to the Dementia Care on Air podcast. Our topic today is adapting the CHA for people with substance use disorders. And I'm very excited to have two colleagues who are both in primary care and addiction medicine specialists, and I will have them introduce themselves. First of all, Dr. Soran.
Hi, Dr. Chodos. Thanks so much for having me. My name's Christy Soran. I'm an addiction medicine specialist and primary care doctor and get to practice in both settings. Really excited to talk with you all today.
Wonderful. And Dr. Defries.
Hi, everybody. I'm Triveni Defries, and I'm excited to talk with this esteemed group today. I'm a primary care doctor at San Francisco General Hospital and an assistant professor at the UCSF Department of Medicine. I'm a consultant on the National Clinician Consultation Center's Substance Use Warm Line and also practice addiction medicine on our inpatient consult service.
Thank you both. And I think now that we've gotten the formal introductions out of the way, we can go back to our regular routine, which is we all work very closely together in the same place, San Francisco General and the Richard Fine People's Clinic and Primary Care, me also doing geriatrics, you guys also doing addiction medicine. So a very well-made match for this topic. And so I'm just going to call you by your first names. I'm really want to also direct people to the webinar that we did in March for a slightly longer presentation on this topic. And we're basically going to be reviewing the main points of that presentation and bringing it down to earth with, I guess, a little more of a collegial conversation about the topic. I think it's incredibly relevant. And I was really happy to do the webinar because I think for those of us, particularly in the safety net, we see a lot of people who are aging and a lot of people who use substances. And it's really important to think about how we could be doing dementia screening and the cognitive health assessment in that setting. So one thing I know we talked about and kind of emphasized is that in general, a screening of older adults for dementia with the cognitive health assessment isn't an approach that would really change. We can still use the cognitive health assessment if someone, let's say they have a history of substance use disorders, they are actively using substances, and that's something we're assessing. So we can still kind of apply this broad approach. But the really interesting stuff that came out of the webinar and all the expertise you had to share was the broader scope of the impact of substance use disorders in older adults and on cognition, and then all the issues around assessment, management, and care. So I'm hoping we can focus on that. What would you guys say we should know in primary care about the impact of substance use disorders on older adults?
Well, Anna, like you said, I mean, this is just something that we're all seeing. We're seeing in clinic, we're seeing among our older relatives. And really, there is data that confirms this, really, that substance use disorder is growing among older adults. And this is due to a lot of different reasons. You know, this is due to aging of the baby boomer generation, different attitudes about substance use, more people who used younger in life continue later into life. And the reason it matters for the primary care doctor like us is because as people age, they're more likely to have negative effects of drugs and alcohol from their other comorbidities or from interacting medications. And it's also important for us to remember that data is showing that the harms of substance use are on the rise. There's more hospital admissions and there's higher overdose rates than ever in older adults. So this is an incredibly important issue for us.
I think one thing I learned maybe early on in training was really focused, I would say most often on alcohol use disorders. Are there like other things we should be thinking about? And it's just such a good point that this is a different cohort, a different potentially group of older adults that have different attitudes about substances and different lifetime exposures than other older groups in the past, meaning, as this current cohort is getting older, like they just have a totally different approach, and it sounds like more frequent or often use of substances. So is there something we should know about, like the particular substances, or even things about specific effects on cognition?
It's a great question. I'm wondering if Triveni wants to answer, are there certain substances we're seeing more commonly than others as this current cohort ages? And then I can talk a little bit more about how those substances affect the brain.
Yeah, for sure. I mean, older adults are more likely to take multiple medications. And so prescription medications, especially pain relievers, are misused among older adults. But really, older adults use alcohol more than any other substance, as you mentioned, Anna. And so we're going to talk, and Christy's going to tell you a little bit about how drugs and alcohol really across the spectrum affect the aging brain, and how we can think about the impact of several different types of substances.
And in that same vein, the most of our information, most of our data, what's been studied the most is really alcohol. But we know with all substances that they have a direct impact on the brain. And in that acute setting, when someone's actively using a substance, whether it's alcohol or cannabis or methamphetamine, it impacts judgment, memory, and behavior. And people often act in more disinhibited ways. And for someone who already has memory problems, those can be heightened. Those kind of negative effects can be heightened. And the safety of use in that setting of acute intoxication can also be have some more negative impacts. With chronic use, the brain actually adapts to the substance and makes several different neuroadaptations, including changes in blood flow and metabolism. Different receptors can be downregulated or upregulated. We make new neuronal connections and even have changes to our epigenetics with chronic use. And that can lead to chronic effects of drinking and other drugs, including on cognitive domains and executive function. And so, as I said, most of what we know is from alcohol, and there is evidence that alcohol can negatively impact memory and can increase the risk of dementia. There is also evidence that benzodiazepines have people who've used them at any point have a higher risk of dementia as compared to those who don't. And another drug, tobacco, that we see current smokers have a higher risk of developing dementia as compared to never or non-smokers. We don't know as much about some of the other substances, although there is evidence to suggest that with long-term use, we can have impacts on memory and higher risk of cognitive impairment. And, as Triveni mentioned, we're seeing more, we have an aging cohort. There are more people who are older living in the United States these days, and we still continue to see higher rates of substance use in older adults. So it's really likely we'll see some of those negative effects from both acute and chronic use more commonly in primary care. And it's really important that we're able to assess for it, able to talk to our patients about it.
There's sort of an interesting phrase that I learned when preparing more and like thinking about this intersection of an aging population and substance use disorder, was that older adults with unhealthy substance use are really an invisible population. And it's so true, because we see our older patients more commonly in healthcare. We often see them for more visits, but unhealthy use of substances is still underidentified, and it's underdiagnosed and undertreated in these patients.
You're so right, Triveni. I can think of so many patients that, in retrospect, substances or alcohol were contributing to the issue we were addressing in our primary care visit, and I missed it. I didn't think about it in that moment.
And to be honest, there are real challenges to recognizing unhealthy substance use in this population. And it's probably helpful to just review some of those, because I think it's true that it can be challenging to recognize substance use problems in older adults. And part of that is because, it's seen as a young person's problem, and there's stereotypes and there's bias about older adults, as well as about people with addiction. So it's something that's hard to talk about. Stigma and shame are really common. They're a really common barrier to addiction treatment. And older adults may have even grown up in a time where there was even more stigma around substance use. There's also the issue that older adults are less likely to seek care for addiction in the traditional addiction treatment settings. And when you do see them in primary care, for example, it might be harder to actually diagnose substance use disorders because of co-occurring cognitive impairment or functional impairments or other medical conditions that might be obscuring what's going on or overlapping the signs of substance use. So it can be challenging, and we're going to talk a little bit about this, but it's also challenging to apply the traditional diagnostic tools that we have to older adults. And all of this, it takes time. And so it takes some extra knowledge to get comfortable and to get comfortable with doing this efficiently. So hopefully the webinar and this podcast are helpful for that.
I think I also just really appreciate what you're saying and the way you're framing it, because it resonates a lot with what we struggle with dementia, which is it can be hard to detect, especially if the person reporting and the patient, aren't entirely aware that it's a problem or aren't interested in addressing the problem. And that here we are really trying to advocate in both realms around substance use disorders and dementia to say, let's be proactive, let's do screening and walk through all the next steps in a way that is normalizing, non-stigmatizing, kind of partnering with the patient and their support system and not offering them what we have to offer. So I'm really interested, if we imagine what we're kind of recommending here in general with Dementia Care Aware, which is you're starting to screen all, if not all of your older adults for cognitive and functional decline to see if they might have dementia. Okay, so you've done that. It's positive. And it might be a functional issue and not as much a cognitive issue that has you in this next steps moment. Now you're thinking about implementing a screen, actually applying a screen to a patient for substance use disorders. Any recommendations, or what would you say about what screens and how to do that screen, given that context you just provided, Triveni?
Yeah, it's a great question, and I can try to help provide some tips. And the first is that you really can't screen or assess somebody once in their lifetime, because as people get older, the same amounts of substance use, even at lower levels, might be riskier or might have more consequences. So it's really important to rescreen and reassess as they age. Screening in the form of like a paper screening form that somebody gets handed in clinic, it has its pros and cons. And ideally, it detects disease earlier and it prevents progression to a more severe substance use disorder. It can help open the conversation, especially if people feel uncomfortable discussing the topic of substance use with their provider. So it's definitely an option when doing the cognitive health assessment to integrate that screener. It's also an option, I say, because it could be limited for some patients that have limited vision, writing, or cognition. They may not be able to fill out that screening form in clinic. And then lastly, the really big issue is that the screening approaches that we have aren't validated, aren't designed for this population of older adults with cognitive impairment. So we have to do our best to be more holistic in our assessment, to use screening, but to think about where it has its limitations. And some of those big limitations are, for the example of alcohol, which Christy and Anna, you both pointed out earlier, is really the biggest substance use issue in older adults. Our screening approaches are based in safer limits. What are the safer limits? Amount of drinks that you can drink in a week and not have negative health consequences. And there are no known safer limits in patients with cognitive disorders. So our validated approaches are tough. And really the recommendation for people with cognitive disorders is that the safest level of alcohol use is none at all. It can be helpful when talking about this to just go ahead and still talk about how much somebody is drinking by using standard drink amounts. And you can actually Google that. I do it all the time in clinic when I'm sitting with a patient. I just Google the standard drink amounts, and you can pull up a nice image with pictures of different kinds of alcohol. And each of those different types of alcohol has a picture for what is one drink of it. So what is a can of beer? What is a glass of wine? And each of those represents one US standard drink. And so you can use that diagram with your patient to still kind of quantify the amount that they're drinking. And it's a good assessment and counseling tool while you're screening.
Triveni, I'm wondering, I've seen in primary care different screener questions in those paper forms that you mentioned. Some of them are like the single question screen or the audit C. So there are standard screeners for alcohol use or other substance use. Are those applicable in this population? Are there better ways that we could better adapt our screening assessments for people who are older, or people who have cognitive problems?
Great question. The audit C is probably the most commonly used screening tool, and that one is based on quantities of alcohol that are not adjusted for patients with dementia. So the issue I talked about before. There is a really nice tool that is very geriatric focused, and I think brings up some important tips. It's called the Short Michigan Alcoholism Screening Test, geriatric version. And it relies on a couple of questions that were really developed for older adults and developed for people who drink less heavily. And it's not just based on how much they drink, but how alcohol is having a role in their life at a different stage of their life where their roles and function might be different. So it asks questions like, when you feel lonely, does having a drink help? Or have you ever increased your drinking after experiencing a loss in your life?
It also has a good acronym, SMAST, SMAST-G. So if you can't remember, look up SMAST-G.
I'll never forget it. Yeah, that's a good one. I want to do a quick sidebar because I'm realizing, and especially as you're talking about like modified limits and safe limits, and alcohol is one of those ones where we, very, very common to have mixed experiences with, use, and it's very socially acceptable in most places. But is there a definition of substance use disorder that we would carry differently if we're working with a geriatric population or in the context of working up a cognitive concern? Because substance use disorder is also in the definition. I think obviously that's a broad category. Yeah. Older adults with substance use disorder, one of the reasons they're underdiagnosed is because the actual diagnostic criteria, that define what is a substance use disorder, it just doesn't always capture well in older adults. And some examples of that in the DSM-5 criteria are something like tolerance or the need to use increasing amounts of a substance for the same effects. Well, when you age, older adults have a lower tolerance for alcohol and they may experience harmful effects at a lower amount. Or another example is there's a criteria about failing to fulfill major duties at work. Well, that may not apply to an older adult. So you really have to keep in mind that the DSM-5 criteria, the gold standard for a diagnosis of a substance use disorder, will need to be interpreted in a more kind of age-appropriate manner. So it seems like we're still in a zone of needing to use some clinical judgment and matching it to the person, which is very common in geriatrics. But I think in primary care in general, I know sometimes can get overwhelming when we're trying to really apply standardized definitions and criteria. But that was really helpful. Yeah, go ahead. Yeah, I think so. And if I had to just summarize, what we want to say about how to assess substance use disorders as part of your cognitive health assessment, it would really be to consider the person's overall health and well-being. The goal is not just to quantify how much they're using of alcohol or of a drug, but really to contextualize how a substance use pattern is playing a role in someone's overall health and well-being. You guys have more tips for how you would work up substance use disorder or continue to go down the path of diagnosing, or we did it?
I think the most important thing, as Triveni alluded to, is having a non-stigmatized, non-judgmental conversation. Sometimes I like to open it up with, after I've, potentially screened someone for cognitive impairment, or I'm talking about their brain health, I open it up with a universal education question. So I'll say something to the effect of, can I share some information about what we know about the impact of alcohol or drugs on the brain? People often say yes, and that's an opportunity to provide universal education, such as if someone does have problems with memory or function, we don't think there's a safer limit to use alcohol or drugs. And so the recommendation really is to not, but we know that's not for everyone, and less is often better. Is it okay if we talk about that a little bit more? So that way you can provide a little bit of universal education and ask permission to talk about it more. And if they're inclined, it's a good opportunity to see how the substance use is impacting their life if they are using substances.
How would that approach, given that alcohol does have, again, this social acceptability, or there's, very often some conversation that people have had before about safe amounts. How would that conversation be different if the substance the person was using was a stimulant or fentanyl or something like that?
That's a great question. We do know that all substance use is increasing in older adults, and that includes substances like fentanyl or methamphetamine. And we know both of those substances can have negative health consequences, both on memory and cognition, but also mortality rates. And so really it's discussing how the individual's using it and discussing their overall, how that fits into their overall health goals. Often the recommendation is to not use. And if that's not kind of within their goals, then it's talking a little bit more about, okay, how can we reduce the negative effects of that substance? And so talking more about harm reduction practices and principles. Some really basic harm reduction principles I talk about with everyone is, less is better. Not everyone's goal is complete abstinence, and that's okay. Even cutting back a little bit can have big impacts. Using around others. And so if there is a negative effect like a fall or a potential overdose, there's someone else around to help that individual. I also really recommend supporting strategies for hydration and nutrition, planning and sleep time for crashing or intoxication, because we know those are really important in older adults and important for overall physical health for people who use drugs and drink alcohol. And then I recommend talking about naloxone with all patients and caregivers and making sure they have it available if someone is using substances.
I think the other door. Oh, yeah, Triveni, did you have more?
No, I was just going to highlight what you said about caregivers, because with older patients, caregivers are so essential to how we can, partner with them in clinic. Are there any tips you have about how to work with caregivers for patients that use substances?
Definitely, that's a great point. I think the biggest important point to remember is first asking permission to involve the caregiver. We still want to respect the privacy and confidentiality of the patient, recognizing there may be some scenarios where someone can't fully consent to different forms of treatment if their dementia is quite severe. But when possible, ask permission and respect that. We do know that when caregivers are involved in the management plan, that outcomes tend to be better. So it is really essential to involve the caregiver. It also can be complex. The caregiver may have, positive and negative effects on substance use, including being the individual they're using the substance with or giving it to an older adult to calm them down or to treat pain. And so really trying to open that conversation to not put blame on the caregiver, to include them in the plan for overall health for the patient that you're seeing. And then also recognizing that the caregivers themselves may need support. We know caregiving is a really tough job and a really important role. And the caregiver themselves may have stress or substance use themselves, and offering them support as well is important.
These are amazing tips. I think probably all of us have a million cases and ideas about patients that we're working with where all of these tips would come in handy. And I'm already feeling the need. We're probably going to have another conversation really about how we have conversations and tips about communication and non-stigmatizing language, specifically working with older adults. I would love to have that conversation in the future. For the last few minutes that we have, I'm hoping we can talk about how we can bridge patients, even if they have, let's say, right, it's getting labeled as cognitive impairment because we're still working it up, or maybe they already have a diagnosis of dementia. Let's say they're using substances and they're interested in reducing use and they want medical help. Any thoughts about treatment for these conditions? And is it different at this time in current practice for older people versus not, or people with impaired cognition versus not?
The short answer is no, it shouldn't be different. The main point I want people to take away is that it's important to offer treatment because it has huge benefits. The primary one being it impacts mortality, reduces mortality rates. And we do have effective medication treatment, recognizing you need to balance each medication with the side effect profile and with the other medications that individuals taking and their goals and polypharmacy. However, I would say if someone has an alcohol use disorder, we have very effective treatment. Naltrexone is a great side effect profile and would be my go-to first-line agent. For opioid use disorder, again, we have very effective treatment that reduces overall mortality. Buprenorphine may be preferable because of its side effect profile, but also methadone is acceptable if that's in line with the patient's goals. We don't have great other medication options for benzodiazepines or stimulants or cannabis. I do recommend treating nicotine use if someone wants to cut back. And then knowing that, medications may not be for everyone, they may be interested in other forms of treatment, such as behavioral treatment. Those need to be adapted to their individual needs. So some may like a group, like seniors in sobriety is one, as long as that group is relevant and they feel like they can participate in it. Also, some programs need to adapt to a slower pace or more repetition or shorter session lengths. So really trying to see what the individual wants to get out of their treatment and finding a program that meets their needs can be really helpful. And then lastly, I want to emphasize that, we talked about social networks and treatment can be a form of social engagement and reducing isolation. So just as you would with any patient with cognitive impairment or dementia, talking about how their social network and loneliness may impact their substance use or brain health and trying to elicit ways that they can engage more in positive social networks.
I actually had forgotten, but you're reminding me of a patient I just saw in consult clinic for some cognitive concerns on behalf of his provider. He endorsed some memory concerns, had gotten sober 3 years earlier. And I can't remember why. There was an event that was a big capturing event for him. And one thing he was very clear about was absolutely every night he went to the same meeting of, I think it was not specific to seniors, and he was mobile and able to get there, despite his cognitive symptoms. But every day it was like a complete routine. And he said he completely relied on it because it was a time of day that he was always really vulnerable to drinking. And it was, a group of people that really helped him. So I should have probably asked him more about what that group was and learned more. But I think, there's so many different kinds of resources and different ways that people learn to manage their use. And it was really, that was an opportunity for me to learn from him.
Definitely. There's a lot of different groups out there, and it takes some time to kind of find one that fits someone's needs. I think for older people, it is about finding one where they feel comfortable, where people around them can relate to the issues they're seeing, which may be different than groups more geared towards younger individuals. I also think of my friend who's an older adult with dementia and who regularly goes to pickleball. And for him, he does that every single day. And for others, it may be going to a mutual aid group every single day, really kind of incorporating that social network in a positive way for their brain health and their substance use.
But Anna, what a wonderful way that you just modeled a non-stigmatizing approach to a patient with a substance use issue, because you sort of framed it as you learned from him, you learned something from him. And that's really the basis of harm reduction, is considering the patient to be an expert about their substance use, rather than the doctor or the provider being the expert, which is how we often operate. So what a great example.
Well, I would love to hear in our last couple minutes some tips you'd like to leave the listeners with, any key points or tips. And in general, just so grateful for your time and expertise overall. But let's go out on a couple of tips. Big
tip, there is no wrong door to addressing substance use. So even in patients with cognitive impairment, with dementia, who are older, primary care is still the right place to open this conversation. You don't have to be a specialist in addiction medicine. You don't have to be working in an addiction treatment facility. You have the skills to open the conversation and include this in your assessment of somebody's cognitive health and really their overall well-being.
And I would want people to take away that we should educate all patients and caregivers about unhealthy substance use and about how it impacts memory and cognitive function. And then everyone should be offered and discussed options in medication treatment and harm reduction to all people, regardless of cognitive status.
Thank you both for your time, for your expertise, and for being just absolutely amazing colleagues. I'm so lucky to work with you guys. Thank you.
Thank you so much for having us. It's so fun to learn with you and learn with our listeners.
Thanks, Anna. Thanks, Christy. Thanks to the whole team. This has been fun.
Thank you for listening, and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia CareWare team. If you want to learn more, please visit our website, dementiacareware.org.